Thank you.
Good morning, my lady. The first witness today is Derek Grieve.
Swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thanks.
Could you commence your evidence, please, by giving us your full name?
Yep, my name is Derek Grieve.
Thank you very much, Mr. Grieve, and thank you for attending today and also for the provision of your witness statement dated the 4th of October 2024. I'd like to start, please, by asking you some questions about the Health Protection Division in the Scottish Government. You became head of that division on, I think, a temporary promotion to a senior civil servant on the 1st of May 2019. Did your position then become permanent in August 2021?
It did.
And what is the Health Protection Division concerned with in general terms?
So it covers a range of policies that includes screening, vaccination, some other activities such as burial and cremations, and a range of other policy areas that relate to health protection itself.
It's plainly concerned with public health and in particular the protection against disease, is that
Yes,
right?
That's correct.
And how does it work with Public Health Scotland?
So Public Health Scotland weren't in existence when I took that division, when I headed that division, but there's a very close relationship between government and the clinical leads of individuals that became Public Health Scotland. So I had regular contact with clinical leads and the organisational leads themselves.
And when you say clinical leads, do you mean the clinicians inside what became Public Health Scotland, as well as chief pharmaceutical officers, chief medical officers?
Within government, yes.
Within government. Between January to June 2020, did you have policy responsibility for the initial response to the emerging pandemic?
I did indeed.
And who did you report to?
So my director was Richard Fogel, the Director for Population Health, of which my division sat within his directorate.
And so he was concerned with population health.
That's correct.
And presumably your division, health protection, was just one of the divisions for which he was then responsible.
That's correct.
Presumably you worked very closely with ministers in the Scottish Government.
I do indeed.
From the First Minister, Nicola Sturgeon, to the Cabinet Secretary for Health and Sport, Jean Freeman, MSP, Humza Yousaf, MSP. I think he was Cabinet Secretary for Health and Social Care after Jean Freeman.
That's right.
And also the Ministers for Public Health as well.
Yes, that's right.
And then did there come a time when you were asked to establish and lead a COVID-19 vaccines policy division?
I was indeed. That was in June 2020.
And who asked you to do that?
It was my director, Richard Fogel. He was also joined by another director within government, Donna Bell.
And it's obvious you were asked to do that as part of the Scottish Government's preparations for the prospective vaccination rollout.
That's correct.
Essentially, you were the senior responsible officer.
That's right.
Is that a formal position, or is that a more informal recognition of the importance of your role in the vaccination programme?
It's more the latter.
As senior responsible officer, did you remain accountable to other officials in the Scottish Government and ultimately to ministers?
Yes, I viewed my role as an SRO as an extension of being able to provide ministers with assurance that the policies were being operationalised and delivered.
And then eventually, did all vaccination-related policy, was it all brought within a single directorate, I think later in February 2021?
That's correct.
Within your functions and responsibilities, were you concerned with the setting up of a programme, the programme for vaccination of both COVID and influenza?
Yes, we took a decision to include flu during 2020 because we were concerned collectively, and that includes ministers, of the impact of if there was a bad seasonal flu season in late 2020 to coincide with an increase in COVID cases.
Presumably, at the beginning of 2020, there was already in existence an immunisation programme and the structure for population level, or at least sectorally level, immunisation for childhood immunisation and influenza.
There was, but during the winter of 2020, of course, we had a number of restrictions because of COVID, so we delivered the flu programme in a different way.
To what extent did having a flu vaccine and a COVID vaccine programme together take pressure off existing primary care structures?
Well, I think it did. It allowed primary care, and I mean that in the widest sense, primary care, GPs, pharmacies, others, to focus on only the work they can do. But it also gave us a chance to test, and in some cases stress test, what would later become our approach to a mass vaccination programme.
You say in your statement that the approach of combining flu and COVID vaccination wasn't, to use your words, universally welcomed by all vaccine leads in the health boards. We'll come in a moment to what the health boards consist of. Well, why do you think it wasn't universally welcomed?
So I don't think it was the principle of combining flu and COVID that wasn't universally welcomed. I think it was this was the first approach we'd taken where there was a nationally led programme. And up until that point, delivery had been completely devolved to individual health boards. This was the first time where it was a nationally led programme, and the programme described itself as being nationally led but locally delivered. This was the first. That was the thing I think that caused a little bit of tension initially.
And within your division, was there, or did you divide up the functions in your division between a programme board and a delivery group?
So in terms of the governance of that programme, yes, I created a programme board, and that was supported by a delivery group which reported into that programme board.
And did the programme board consist of I suppose, the clinicians, the scientists, so the chief scientist, chief pharmacist, Public Health Scotland, CMO, CNO, and members of the Scottish Government Health Protection Division?
Yes.
And do we take it that the division became responsible for the setting up of all aspects of the vaccination programme, so supply chain, the vaccination sites, communications and engagement to drive take-up, operation security, governance, and the workforce? The
programme did, yes.
Let's look, please, at your statement, INQ 000474396, at page 43, where you set out references to a number of the other bodies in the Scottish Government and in Scotland which were concerned with the vaccination programme. If we just go back to page 43, please, and scroll out. Thank you very much. We can see in paragraph 108 that the NHS health boards led on the delivery and rollout of the COVID-19 and seasonal flu vaccines. We'll look at NHS health boards in a moment in greater detail, but essentially they are regional health boards within the NHS which deliver primary care.
They deliver healthcare.
Healthcare. And are these health boards the result of the transformation process which had taken place and was still going on within the Scottish Government over the previous 2 or 3 years?
In relation to vaccination?
No, in relation to their constitution and set-up. There was a transformation programme, we understand, which led to the creation of NHS health boards.
So the transformation programme, so the health boards were in place, have been in place for a number of years. The transformation programme I think you're referring to was the vaccination transformation programme that hadn't been fully implemented at the start of the pandemic, but the approach we took through the flu vaccination, COVID vaccination programme was predicated on that the models underpinned by the vaccination transformation programme.
And what, in essence, was the transformation process? What did it do in practical terms?
So the vaccination, I'll use the acronym, the VTP, was designed to modernise vaccination. So that included, for example, developing new IT systems, having a new tracking system and call-up system for individuals for all immunisation activity, and importantly, removing vaccinations from GPs. And that was part of, I think, the 2018 GP contract that was agreed. So that at its heart, it was designed to do that.
All right. Ms. Grieve, will you just slow down a little bit? We're going quite fast.
Apologies.
No fault at all, but if you just go a bit slow, it's easier for the stenographer. And then if we can just scroll out and look down further towards the bottom of the page, we can see there you refer to the role that national NHS boards played in the flu vaccination, COVID vaccination programme. There's a reference there to NHS National Service Scotland, which provided logistical support, programme management support, a vaccine helpline, an online digital tool. And if we go back out, NHS 24, were they concerned with developing and managing vaccine information pages online?
Yep.
And over the page, NHS National Education Scotland for supporting material and developing the digital platform. And then Public Health Scotland, to which you've already referred, it provided patient leaflets, posters, digital assets, and the clinical governance group.
Yep.
So there were a number of moving parts, and to a very large extent, all parts of the public health bodies in Scotland were involved.
Yes.
Mr. Keith, are you going back to the question of removing GPs from the vaccination?
Yes.
You are going back
We'll
to-
come on to the structure in a moment. Yes, indeed.
Thank you.
The paperwork or the material before the inquiry suggests, and in fact, my lady will go straight on to this topic, that the material before the inquiry tends to suggest that at the beginning of the vaccination programme, there was a more limited use of GPs and community pharmacies. Is that right?
That's correct.
To what extent did GPs expect to be part of the vaccination programme from the start? And to what extent, or why was it that they weren't as involved at the beginning as they ultimately perhaps proved to be, particularly in the case of rural areas and the Highlands and Islands?
Okay, well, at the very start of the vaccine rollout, of course, we were prioritising the most vulnerable, and we did use GPs to identify and vaccinate the over 80 vulnerable when they were at home. So we did use GPs for that purpose. But the priority group at that time was the very elderly and care homes. And as I think have been mentioned before, supply was a constraining factor, and there was a huge amount of logistical challenges associated with supply. In short, we didn't use primary care, be it pharmacists or GPs, extensively because some of the constraints with the vaccine, how it was delivered, they came in large trays, they had a huge amount of complexity around handling and transfer, and in Scotland, we didn't have GP surgeries that had the breadth of coverage that we felt confident could use the vaccines without a high level of wastage. Because supply was so constrained, the programme had a laser-like focus on ensuring we didn't waste vaccine wherever possible. So that drove us to a model which protected as much as possible all vaccine supplies that we received.
And can you just explain to us what the health boards therefore actually consisted of? Is it an administrative structure responsible for the provision of primary care, which includes within its remit GPs and other healthcare systems or delivery systems, but which then became responsible for identifying and running the sites in which vaccines were delivered? Is that the nub of it?
Pretty much. So It varied, but the structure in Scotland has something called integrated joint boards, which is overseen both by the health board and the local authority. So some health boards devolved responsibility through these integrated joint boards, but ultimately the health board retained overall oversight of the activity in their area.
And therefore, the GP system is just one part of these integrated health boards.
Exactly right.
And I think we've seen in the paperwork as well that one of the advantages of having the health board system that you have in Scotland is that directors of public health are ex officio members of the integrated health board. So you have a public health element being inputted into the system at that level.
Exactly right.
And in essence, therefore, what the health boards did was identify and set up a large number of vaccination sites across Scotland, less so perhaps in the more rural areas, but they were sites that weren't run by GPs themselves.
That's correct. Although it's important to say that although we didn't use GPs in their surgeries, we did extend the offer for GPs and pharmacists and many other primary care clinicians, such as dentists and others, to be part of the vaccine workforce, often within vaccination centres.
Many of these issues are reflected in a policy document, which I want you please to look at and identify for us. We're not quite sure of its etymology. INQ 000499465. Mr. Grieve, this is a document which talks about deployment of COVID-19 vaccines to care homes, and it talks about the position in England and over the page, on page 2 in Scotland. And it says under the heading assessment, in Scotland, we're not calling forward over 80-year-olds for vaccination in this first phase, with the exception of those who are care home residents or long-stay inpatients. And there's a reference to 950 primary care sites as having been set up, and then references to why you've adopted the approach you did, and also the impact on GPs in England, and you draw a contrast, or somebody draws a contrast to the position in England. We assess that this must be a document dated around mid-December, because it talks about the imminent rollout of vaccines through GPs in England, and that started on the 15th of December. Do you recognise this document?
Well, I actually don't. I mean, I recognise the content of it, but as you've alluded to, I'm not sure who it's from or who the recommendation is being made to, if it's the programme or ministers, but I do recognise the content of it.
Is what it says about the number of reasons for the approach that was adopted in Scotland correct? So there were difficulties with packing down and supplying vaccines to GP practices, that there wasn't a primary care network equivalent arrangement in Scotland as there is in England, and none of the GP practices in Scotland had the ability to use the whole, I'm going to say pizza box, the whole 975 doses within the very limited amount of time that the Pfizer vaccine in particular had to be used within.
That's correct, and that's what I was referring to about the wastage.
What does pack down mean in that context?
Divide.
Thank you.
My lady, that's not my word. You importantly say, or somebody says, there are more over 80-year-olds than we currently have vaccine for. And so if you were to call this group forward, we'd raise expectations that we then cannot meet. What was that problem?
I think, as we alluded to at the very start of the programme, supply was limited, and we didn't have a high level of confidence to be that would ramp up very quickly, and therefore we literally couldn't have vaccinated all the 80-year-olds on the first day of the programme starting. So we had to be relatively measured in our plans and pragmatic, recognising that for many of these over 80-year-olds, we need to give them time to make arrangements. Many would have to be supported to come to get vaccinated, and that took a bit of time, and equally because we didn't have the supply. Sorry, I'm maybe speaking a bit fast, so I will slow down.
Slow down, Mr. Grieve.
So that allowed us a bit of time to ensure that our deployment plans aligned with our expectations on supply.
the expert evidence commissioned by the inquiry from Dr. Castaner, Bush and Dr. Chandler states that by comparison to the rest of the United Kingdom, you delivered the Pfizer vaccine in particular quicker into care homes than any other part, and that you had a policy of vaccinating care home staff on the same visit as you vaccinated the residents. So you got the numbers in care homes up very high, very quickly, relatively speaking.
Yes, we did, but that wasn't the objective. The reason we managed to do that was because the Chief Pharmaceutical Officer had found an exemption within the Medicines Act that allowed us to pack down or break down these pizza boxes, as you alluded to, under supervision of an NHS pharmacist. But because of the licence restrictions on Pfizer, the vaccine had to be administered by an NHS employee, and that's why, for example, we couldn't use care home nurses. But it did allow us to take the vaccine to care homes. But it was a very pragmatic decision. Given we knew that the care home workers were part of the priority group, if you're in the care home and have the vaccine there anyway, in order to, one, use that vaccine and ensure there's minimum wastage, it made sense to offer the vaccine at the same time to the staff as well as the residents.
Was that not happening in England? Do you know?
I honestly can't comment on what was happening in England.
All right. And then, in a general sense, when Delta became the dominant strain of SARS-CoV-2, were there changes in the rollout approach? Presumably by that time, of course, you'd worked your way through the priority lists, and everybody who was on that priority list had at least been offered a vaccine.
I mean, to be perfectly candid, I can't recall a time there wasn't changes to the programme. The evidence and advice from JCVI and MHRA required the programme to pivot and change constantly through the time I was on it.
Latterly, there were more mobile units, delivery of vaccines at agricultural workplaces and shopping centres and education centres. So there was a more tailored, perhaps a more specific, but a more varied way of delivering vaccines as time rolled on.
Exactly.
And give us some idea, please, Mr. Grieve, of the degree of scale-up between mid-December 2020 and February-March 2021, by which time it was expected that the vast majority of the priority recipients would be offered a vaccine, and indeed you met that plan.
Yeah, so we had published a vaccine deployment plan in September with what we thought was going to be our first autumn-winter programme that combined COVID and flu vaccines. But you're right, that all changed when Omicron became present and the JCVI offered advice, and the programme had to massively scale up to deliver, and there was a whole range of activity had to happen almost overnight. That included both new vaccination centres, increasing the opening hours of vaccination centres, the staff, the workforce that went with it, reducing the 15-minute observation time. We reduced that to 5 minutes, and that allowed us to increase the flow through vaccination centres, and as well as a huge marketing campaign, which I think we called Boosted by the Bells, I think, and that enabled us, I'll just check my notes, I think we got 2.9 million people vaccinated before the bells through that increased activity.
By comparison to a routine immunisation programme, where there might be, I suppose, a passage of, or an elapse of time measured in months, years perhaps, between the initial planning and the actual rollout, how compressed was the time between the beginning of the planning for the COVID-19 vaccination programme and the first delivery of a vaccine?
It was incredibly compressed, and although I'm here today, I want to put on record my huge appreciation for the team that came together, the organisations you've mentioned, as well as working in those organisations. We had embedded staff from these organisations, and they pivoted on a pin. Much of the activity had to be taken in parallel, and we couldn't always provide some of that work in advance of JCVI opinning on a matter. So as soon as we had a sense of what JCVI were likely to announce, that a whole range of activity was initiated, everything from working out how we identify individuals, drafting protocols that were going to be used, developing training material for the workforce, developing patient safety material, and we managed to condense that timeline between receiving JCVI advice and starting to vaccinate to sometimes 7 days, and that was phenomenal by the team involved in that.
In what state were the relevant data systems? Presumably, there was an obligation to record in health board records the fact of each individual vaccination within a certain amount of time. Was it 24 hours?
So in the main, it was real time. The vaccination management tool was a digital tool used by vaccinators on site, and it was linked directly. So as soon as the clinician sat down in front of the patient and entered the records, it was uploaded immediately. But if for any reason there was the IT systems went down, then we, generally speaking, at the end of that working day, the team would upload the records. So it was less than 24 hours.
At the commencement of this vast piece of work, was ethnicity of the patient, of the recipient of the vaccine, routinely recorded, or anticipated that it would be routinely recorded in the data programme?
It wasn't at the very start of the programme, but we did develop that data set and added, and I think it went live in November 21.
And do you know why it wasn't until November 2021 that you were able to record ethnicity in the take-up data system?
So we identified the gap quite early on, and I think, as I said in my statement, we established an equalities division within the Scottish Government quite early on in the programme. But the IT systems we're referring to were built for a purpose that they and had to continually change through the programme, with lots of different dose schedules, different vaccines, different call-up arrangements. And the IT colleagues who were developing those systems were cautioning against the risk of these systems of being adapted to the point that they might fall over. So it just took time to get those fields added. It would have been better to do that sooner, but it was incredibly complex. But now it's embedded and is a mainstream of the programme itself.
What was the complexity? I mean, presumably the system had to be largely built from scratch. There hadn't been a population-level vaccination programme before. Why wasn't it just a question of putting in a code reflecting ethnicity into the system when the data is inputted? I'm sure it's a great deal more complex than that, but could you explain why it couldn't be done sooner than it was in the event done?
Well, I'm not an IT expert. I rely on the experts that tell me how difficult it is. I'm told by the colleagues that were leading on this work, it's not as simple as that, because as I alluded to, the initial programme was built for one vaccine with a particular dose schedule, a call-up arrangement, and we were constantly through that early part of 2021 changing that system as new information became available. For example, not providing AstraZeneca to a particular age cohort. That had to, the system had to reflect all of that, so we didn't inadvertently call up people that we didn't want to call up and give them the wrong type of vaccine.
All right. And may we take it that the inclusion of ethnicity as a particular code in the data system was of great assistance because, of course, it allowed you a far better understanding of rates of take-up amongst ethnic minority communities? Exactly.
Not just at a national level, but at a board level and even at a community level and a clinic level. We could see, as I said, almost in real time, what uptake was like in different groups, and has allowed us, both the national team and the local team, to adjust. And that could mean our messaging, it could mean our comms activity, and we could see if some of that activity was having an impact in vaccination rates the following day, for example.
Next time, of course, the system will already have been in operation. No doubt it will be a great deal easier in the face of the next pandemic to set up a recording of vaccination data system which includes all the codes and all the information that you would wish it to have to make the system work more effectively.
Yes, and I think as I alluded to in my statement, this was all being built at pace, and and it's credit to the team that they managed to do that. But yes, you're right. There's lots of lessons we've learned, and as I've alluded to now, ethnicity is a standard cell in the recording of vaccination data.
Funding, Mr. Grieve. The inquiry is aware that prior to the deployment of vaccines, it was agreed that the vaccines would be physically allocated using what's known as the Barnett formula, which is the process by which public monies are divided between all the nations in the United Kingdom. And Scotland would therefore have access to, I think it was 8.28% of any COVID vaccines that would end up being procured by the United Kingdom government. Did that funding division work, bearing in mind the demographic particulars of Scotland? So, for example, it wouldn't necessarily reflect, perhaps in one nation rather than another, a greater number of more vulnerable elderly people who needed the vaccine quicker.
If there was time, if we had a time to do full population level modelling and base our supply forecasts on that, then that would have been a preferable model. But the Barnett formula, using the Barnett formula itself, I can't recall an instance where we felt our deployment was having to be slowed down because of our allocation of available vaccines. It's probably important to say that it would have been a problem if BES and the UK government had only secured enough vaccine for the total population, but they didn't. They secured more vaccine than we needed. So it was 8.28% of the relative portion of the totality of the stock as it came in.
And presumably, because the supply chains went up and down in terms of volume and availability, and there were times when there was more supply than you could deal with, and other times when you had to very carefully apportion the supplies and make sure that you never ran out on the coalface. The fact that you were given a overall percentage of the entire vaccine supply made no real difference operationally.
Exactly. What we found, there was really good and close cooperation between the SROs, and that includes the SRO from BES on supply. So each of us would share our deployment plans, and each nation sometimes was going a little bit faster or slower than the others. And there was a really pragmatic approach to ensuring we each supported each other's deployment. And as I said, I cannot recall an instance where we had to rein back our delivery because of delays in supplies, other than shocks in the supply system, such as batch failures, which weren't anticipated.
So that system appears to have worked. Your relationship with the Vaccine Task Force. The decision had been taken that the United Kingdom government would be responsible for procurement, and that is what the Vaccine Task Force was primarily concerned with. But was Scotland, as with all the other nations in the United Kingdom, invited nevertheless to be party to discussions, or some of the discussions of the VTF, so some meetings that they conducted?
We were indeed, yes.
Were you there as an observer or as formally part of the VTF programme board as it happened?
I wasn't an observer, but we were briefed by BES, but there was not a governance role in that capacity.
In your statement, you refer to the quirk that the VTF's governance system, by which the VTF formally reports to the United Kingdom Secretary of State for Health and Social Care, had fallen behind the reality of the position, which is that post-devolution, public health was a matter for Scotland, Wales and Northern Ireland, and the VTF wasn't reporting formally or in any sense at all to Scottish, Welsh and Northern Irish public health ministers.
I think that related more to the JCVI rather than to the VTF. So the JCVI has been in place for a considerable amount of time, but you're right, the governance of the JCVI has not been updated to reflect a post-devolved settlement. So the JCVI formally reports to the Secretary of State for Department for Health and Social Care. And then it is incumbent upon the Department of Health and Social Care to inform other health ministers. It also, if I may, it also means that the timing of when JCVI advice is announced to the public is decided by the Department of Health and Social Care. And finally, that also means that the Green Book, which is often described as the Bible, that the UK HSA write, which translates JCVI into the operational detail of how it should be delivered, is not undertaken in a way that has Four Nations sign-on, and there were times, as I think I alluded to in my statement, where there appeared to be a misunderstanding of the way in which health is delivered in a devolved setting.
You're absolutely right, of course. I confused myself because the VTF reported to the Secretary of State for BEIS, and it was within BEIS that the VTF was a departmental body. The JCVI was a statutory body reporting to the Secretary of State for Health. Did it matter in practical terms that there was this absence of governance reporting from the JCVI to the Minister of Health in Scotland?
It's difficult to say, but there were occasions where there was a suspicion that the JCVI, despite having a member and observers, didn't completely understand some of the subtle nuances in Scotland. So whether that be, for example, Scotland has a different academic year, and school children go back to school in the middle of August in Scotland, and it's slightly later in other parts of the UK. It wasn't immediately clear that the JCVI understood that, and therefore, and there were some other examples, but there were times where we weren't sure the JCVI understood the complexity. Carers may be another example that you may wish to come on to.
But in practice, there were always representatives from Scotland, Wales and Northern Ireland at JCVI meetings. So you were able to say, well, hang on, you've gone wrong here. Actually, the academic term in Scotland starts at a different time to England, and therefore the premise of what you've just decided is wrong. You always had that opportunity.
Yes, in theory, although the observers and the members of the JCVI from Scotland were often clinical leads and not
Policy or...
Indeed, and maybe didn't have that wider, broader policy perspective of delivery.
So perhaps the question of who attends and who observes at JCVI meetings on the part of devolved administrations is something that needs to be looked at.
Perhaps as... Or indeed the governance of the JCVI to reflect a post-devolved settlement.
All right. You've already said that you worked very closely with your fellow senior responsible officers. Yep. There was, I think, a very high degree of openness and candour, as we'll see in a moment from some of the WhatsApps. That system, that relationship appears to have worked extremely well. Would you agree?
I would indeed.
And did that process allow for almost every aspect of the vaccination programme in the United Kingdom to be debated, from statistics to rollout, the issues of dose interval, mixing vaccines, availability of stock, prioritisation, wastage, particular sectors wanting priority vaccination, workforce matters, everything?
Yes, although we each, I'm sure, had a great team we were working with in our own nations, there was a bit of a kindred spirit, and it was good to be able to at times offload, but also check how others were dealing with some of the same issues.
Presumably, there were always going to be times when documents were produced by the United Kingdom government and not enough time was afforded to the devolved administrations to comment on them, and also when politicians said things in the public domain which perhaps required correction subsequently, or there were unattributed comments or observations from unknown sources in Westminster which caused horses to shy and a certain fluttering of feathers.
Yes, there were. And in particular, I seem to recall January 2021, there was a series of some of those tensions. And that was at a time where confidence it was really important that the public had confidence in the programme. And there was a risk that some of that activity would put that, would create a lack of confidence, which would may mean people not coming forward. I don't think it had a material impact on the programme's ability to deploy, but it made what I think was a really difficult job even more difficult.
So this is an important facet of the position. Whilst at a policy and at an administrative level, it was always possible for all of you to get to the right endpoint, and what needed to be done was done. It was important to maintain public confidence in the vaccination programme, that you were seen to be given enough time to agree joint positions, to agree to vaccine strategies, and so on.
So there was broad agreement on some of the key elements across the four nations. So, for example, when the date in which we started vaccinating a particular cohort, or how we were intending to prioritise different groups. So there was broad agreement on that side. But it was equally important for us all to understand there was subtle differences in the messaging, because we each had a different system, for example, of calling people up, of inviting people, of you've alluded to England using primary care networks. We didn't. So there were subtle differences that we all had to ensure were carefully understood by each bit of the programme across the nations, but also was embedded in our communications.
And especially when they were being talked about in the public sphere.
Indeed. And some of the criticisms around supply, for example, were extremely unhelpful and at times untrue.
Are you referring there to the fact that I think at the beginning of January 2021, there was unfair and inaccurate but unattributed commentary in London concerning the speed at which the Scottish Government was delivering the vaccines which it had been apportioned under the Barnett formula?
It wasn't just unattributed. There was some, I think there was some attributed comments, but yes, and I think if I recall correctly, the number that was being quoted in the media was the number of vaccines that were allocated to Scotland, not delivered. And it's quite difficult to provide a vaccine to someone in Wick when the vaccine's sitting in a warehouse outside Liverpool.
Is that a reference to a comment made in the public domain by perhaps the Secretary of State for Scotland?
That's correct.
All right. But the position was corrected?
Subsequently, we agreed with the UK Government that we would publish supply figures, and we did that on a routine basis.
All right. Let's look, please, at just a couple of examples of where friction arose, but where ultimately an agreed position was reached and the problem was solved. INQ 000498602. This concerned the review of the agreement to the UK vaccine strategy. Is that correct?
That's correct.
So in this letter, Jean Freeman, the Minister for Health, wrote to the Secretary of State for Health and Social Care, Westminster, about the process by which the draft UK vaccine strategy was to be agreed by all the nations. And essentially, she stated and complained of, or she stated that there had been an exceptionally short time frame provided for comment by the devolved administrations. Is that right?
That's correct.
Were you able, nevertheless, to reach an agreed position? So were you able to sign up to and comment on and no doubt amend as you saw fit the combined UK vaccine strategy?
So this may sound a bit civil servicey, but in the end we agreed it to not being a UK-wide strategy, but an update document. I can't exactly recall what the UK government called it, but we didn't have it as a strategy. But we did reach agreement, and we did each SRO provide information to Department of Health to allow them to publish a document on the date they had wanted to publish.
So Humphrey Appleby would have been intensely proud of you, Mr. Grieve. You were able to reach a position whereby you agreed to the substance of the document by calling it something different.
In essence, yes.
All right. There were very many WhatsApps between yourself and your fellow SROs, INQ 000477804. let's start, please, on page 4 of this document, which is extracts from the 15th of December 2020. And if we go, thank you very much, straight to 20:55:05, so around about 5 to 9 in the evening. Derek Grieve, I think this merits a deeper conversation. I'm not sure my minister agrees it's necessarily a UK programme. Is this in the context of the UK vaccine strategy?
I think this was in relation to an earlier message
Right.
from, it may have been Emily, where she references the Prime Minister and the Secretary of State believing this was a UK-wide programme, and I was correcting that.
All right. And presumably there were multiple occasions on which you had to debate the merits of documents produced at the UK government level. You had to debate whether or not they were accurate, whether they properly reflected the position in each of the devolved administrations, and of course whether they were right. And that was part and parcel of the process by which, in a devolved nation, you have to agree something that's got a very high level of UK government input.
There was agreement that all 4 bits of the UK had to work together and respect each other's different approach. But as I said, particularly in January and the December, the thing that was on all of our mind was the importance of the public having confidence in the programme. And if we had put out information which was clearly wrong or inaccurate, that could have dented confidence.
On page 11 on the 4th of January 2021, there is some communication concerning communications and the issue of communications. So page 11. Thank you very much. 4th of January at 20:49. Gillian Richardson, on behalf of Wales, says no one is handling comms to 3 non-English nations. Ministers furious. What do you understand that to be a reference to? Was there an issue with the way in which, as you say, on a communication level and a public level, communications being made on behalf of all the nations were correct?
Yeah, I seem to recall, and I think there's an earlier message in this chain where I asked Emily at 1958 if the PM was about to announce the timeline for completion. And I recall the Prime Minister did make an announcement at 8 o'clock that evening about England's timeline for completing priority groups 1 to 4. We didn't know that announcement was going to. Well, I didn't know that announcement was going to happen. I don't think any of the other SROs did. And as soon as that announcement was made, understandably, all parts of our respective systems were asking us, "Can you match that timeline?" And we had predicated our deployment plans on the information we had about incoming supply. And again, we hadn't had those discussions about understanding if that assumption was right, because our deployment was based on using the maximum amount of supply. And our suspicion was that colleagues in England knew they had more supply than we had. As I say, I didn't know that announcement was being made.
So it was a technical issue, ultimately, but one that was resolved.
Yes.
Were you occasionally bedeviled in your work by false or inaccurate accusations, as you saw it, being made in the press and in the public domain about the state of vaccination in Scotland and indeed your colleagues, respectively, in their own nations?
I think and I suspect others dealt with it as the flotsam of jetsam of working in the programme, but it meant that when there was misrepresentation out in the public domain, we had to work doubly harder to ensure the correct information was out there. And as I've said, underpinning that was ensuring the public had confidence in the programme itself.
If we could look at page 16 at 11 a.m. approximately, one of you refers to the undesirability or the depressing nature of politics of accusation. So page 16, thank you very much, at 11 a.m. and 41 seconds. Derek Grieve, it was you. The politics of accusations relating to delivery being out of sync with supply in Scotland is proving to be challenging. Well, was that a glorious piece of understatement?
So I think this relates to what you were asking about earlier, where some of those unattributed and later attributed sources were talking about supply figures being in the public domain.
Was there a particular problem in relation to the inability of the devolved administrations to put data into the public domain, at least until late January, and therefore being unable to bat off some of the unfair accusations that were being made concerning practical delivery and rollout?
That's exactly right.
So if we look at a letter, please, INQ 000498603, Jean Freeman had occasion to write to Matt Hancock on the 31st of January, and she copied in Vaughan Getting in Wales and Robin Swan in Northern Ireland. And she says this in the second paragraph: in recent weeks, devolved administrations have been put in the untenable position of being unable to share this data at the request of the Vaccine Task Force, but at the same time see these figures being briefed to the media and apparently to elected representatives of the Conservative Party. Well, there's a little political dig in there, but putting that aside, was this issue of, from the position of the devolved administrations of them being unable to put data into the public domain resolved? Did they continue to be unable to put into the public domain, or did you put into place a system whereby weekly or monthly you could put the figures up?
Yeah, so it was resolved, and we did put supply information up on the Scottish Government COVID website. I think just to say, the programme and Scottish ministers were really keen that we provided as much information to the public, Parliament and the press. So we published a series of deployment plans to help explain to the public and others what the programme was doing and why it was doing it. Particularly, and that was particularly important because we were asking quite a lot of people to wait their turn, and we needed the public to understand why we were taking the approach we were taking, and having some of these figures that we weren't able to rebut was putting that at risk.
Now, Ms. Grieve, we can look, I think, at some of the more specific practical aspects of the vaccination programme in Scotland, starting with, please, the COVID-19 vaccine deployment plan. Did you bring together or produce an overarching plan for the delivery of vaccines in Scotland?
So, as I alluded to, there was a series of plans. I think the first was published on the 13th of January 21.
And presumably you'd started working on these plans months before.
We had, but of course we didn't receive the detailed advice from JCVI and MHRA until beginning and through December.
Well, you didn't know that any vaccine would be authorised until the beginning of December.
That's correct.
And you therefore didn't know for sure what the practical consequences would be of having vaccines that had to be delivered at minus 70 degrees centigrade.
Exactly right.
All right. Could we look, please, briefly at the vaccine deployment plan? I can't tell you, I'm afraid, which emanation this is. Oh, it's the 14th of January one, so it's the first plan. Page 3, the third paragraph, we can see there that you envisage, and indeed this is what happened, that vaccination will take place in care homes, GP surgeries, local vaccination clinics, community pharmacies, mobile vaccination units, and mass vaccination centres. Page 6. Unlike, I think, the overarching plan in England, when you set out the cohorts of persons who would receive vaccination in the priority list, you were able to, and you did, estimate the numbers of people who were expected to be vaccinated in that cohort. And we can see there all the JCVI groups, 3.375 million.
That's correct.
And did those figures over time prove to be broadly correct?
They were. This, I suppose, is an illustration of the modelling that we used to help us understand when we'd achieved maximum uptake against each cohort. It's probably fair to say, though, that cohort 6 was more complicated than we first anticipated, but generally speaking, these numbers broadly align with our expectations.
We'll look at it in a moment, but cohort 6 had within it, did it not, the reference to those with a higher risk of serious disease and mortality and unpaid carers, and that gave rise to terminological definitional issues as to who might be regarded as being at higher risk and who might consider themselves an unpaid carer.
That's correct.
All right. Who is responsible for the training and deployment of vaccinators?
So that was each territorial health board had that responsibility, but they were helped enormously by colleagues in NHS National Education Scotland, who developed a suite of products and training tools to that the territorial boards could use.
And we've heard evidence from Dame Emily Lawson to the effect that there was a protocol drawn up in London in relation to the training of vaccinators in England. Was a similar process adopted in Scotland by which a highly prescriptive list of directions was drawn up for use in training?
Yes, so every time there was a different JCVI advice, or indeed advice from the MHRA, then we often updated the protocol and issued that as part of the package to develop and train both existing vaccinators, but also new vaccinators joining the workforce.
You've referred already to the issue in cohort 6 of unpaid carers. Could we look, please, at a submission that was prepared for the Cabinet Secretary for Health and Sport, INQ 000376371. Did this come from you, Mr. Grieve? Do you recall?
It didn't come from me. I think it came from the unpaid carers policy team.
All right. Within your division or within the health protection division?
It came from another bit of the health family, but I would have seen and I would have been part of the sign-off of this advice before it went up.
All right. Paragraph 6 states that official statistics indicate there are around 690,000 unpaid carers in Scotland, although that may be likely an underestimate. So there was a significant problem, or at least the terminological debate or the definitional debate about who was an unpaid carer had the potential to be of enormous impact given the sheer size of the cohort.
Yes, but it's important to say that there was a piece of legislation in Scotland, the Scotland's Carers Act, which set out the definition of a carer in Scotland, which I don't think was the same elsewhere in the UK.
Indeed. And if we go over the page to page 2 at paragraph 10, the problem was not the problem lay therefore not in the absence of that statutory structure, but that there was no single register of unpaid carers and local data was patchy.
That's correct.
All right. And presumably there's a difficulty with people attempting to self-identify because whilst that may be absolutely fine in practice, it doesn't allow the government to be able to understand in advance how many people are likely to self-identify.
Yes, so there were some unpaid carers who were in receipt of benefits, and we used that data to identify and target them for invitation. But you're right, for those that were not in receipt of disability benefit or benefits, then there was no way for us to immediately identify them, and therefore we moved to a self-identification model. We did put in a couple of controls, though. So we used in the vaccine helpline, we adapted the script that when somebody phoned up and self-declared to seek assurance that they were actually an unpaid carer. And likewise, if somebody was booking an appointment on the system, we asked them a series of questions to try and filter out. Of course, there was always a risk that somebody may be playing the system. Generally speaking, though, the level of unpaid carers we administered was broadly in line with our expectations.
And do you assess that the system you put into place did allow effective offering of vaccinations to unpaid carers in the way that you had obviously wished?
Yes, I do.
Scotland has a number of rural communities. That's obvious and self-evident. How did you alter the system of delivery on the ground to ensure that those rural and particularly Highland and Island communities were properly served?
So, as I alluded to, we devolved responsibility to each health board, but we gave each the central team gave each health board quite a lot of support. So when Highland, for example, and the islands were developing their deployment plans and explaining to the programme where they were having vaccination clinics, how they were supporting people to get to vaccination, these were scrutinised and sometimes challenged and changed. But we also, particularly in the Highlands, used far greater role of outreach activity. So vaccination teams going to rural and remote areas. And to that end, we did something called bundling, which might sound a bit technical, but in essence, we gave authority for the health board to not stick rigidly to the prioritisation group when it made operational sense to go to a community and just vaccinate, for example, a whole village or an area, because that reduced the risk of vaccine wastage.
Was the health board or health boards responsible for, in particular the Highlands and Islands, able to roll out that more particularised, more tailored form of delivery from the start of the vaccination programme? Or did it not really get going until later?
So the role of bundling and outreach was tended to be deployed as we came down the cohorts a little bit, but bearing in mind the very start of the programme was directed at care homes and health and social care workers. It'd be unfair for me to say it was we got that bit perfectly right. There was challenges. There was absolutely challenges with all of that. And as well as rurality, of course, there was inclement weather. And we were vaccinating over winter in the early 2021. And that had an impact on people's ability to travel to vaccinations. And that's not just people receiving the vaccine, but also the workforce.
Would it be fair to say that in relation to some of the younger age groups, age cohorts, for example, the over 70s and the over 60s, and in relation to the clinically extremely vulnerable, or you would say high clinical risk, in the Highlands and Islands, offers of vaccination, the delivery of vaccinations, didn't proceed at the same pace as they did in the more urban areas?
So it's a more difficult job in rural areas by very definition, because but there was the same level of support, of outreach. I should also mention each health board used third sector organisations to both pick up the individuals at home and take them to and back for the vaccination. But of course, within rural areas, that's a more difficult job, and you can, by its very nature, in an urban area, you can support more people to get to clinics than you can do in a rural area.
Did there come a time in May 2021 where you recommended the approval of funding for the Scottish Ambulance Service to assist in the rollout, particularly for more rural areas, so they could get out to particular houses, to the housebound, yep, and also to those who are unable to travel or who fear the risk of infection by travelling to vaccination sites?
Yep, we did indeed.
How big a contribution did that Scottish Ambulance Service facility make?
That was hugely beneficial. And as you alluded to at the beginning of the programme, it helped us to target the most vulnerable. But as we came down the age cohorts, it also allowed us to deploy outside football matches and shopping centres and areas where the younger population are more likely to go and take the vaccine to them rather than them ask them to come to the vaccine.
In relation to the vaccination of 12 to 15-year-olds, the inquiry is aware that in England, vaccination of children was generally, although perhaps not exclusively, but to a very large extent, carried out by SAIS, the school immunisation service. In Scotland, you did it differently, did you not?
We did.
And how did it differ in general terms?
So it's fair to say that up until that point, we had delivered, for example, the child flu vaccine through schools. We had done that. But the programme took the view that if we had done that with the COVID vaccine, there wouldn't be the opportunity for parents and guardians to have that informed consent discussions if they had any concerns about the safety of the vaccine, given the advice from JCVI was nuanced and more balanced. So we felt it was important to offer a community-based approach. And I think, as I also said in my statement, it also allowed us to develop, for example, child-friendly vaccination clinics based on conversations we'd had with the Gold Coast in Australia, who were already vaccinating children. It was a bit of a risk. I'll be fair, we didn't know if it was going to work. But to be fair to the programme and indeed to ministers, they agreed to take that risk. And I think in the end it demonstrated that we had quite high and good uptake of vaccination for children.
You had a higher uptake of vaccines amongst 12 to 15-year-olds in Scotland than I think was achieved in England. Is that right?
Initially, I think everybody broadly caught up with each other, but certainly there was a point where Scotland was slightly ahead of the league table.
And what do you mean by, in the context of the vaccination of 12 to 15-year-olds, community-based approach, a community-based approach? What does that mean in practice? Does that mean mobile units, community hubs, or attending local vaccination sites under the Health Board?
It's the latter. It's a local, often a local vaccination site, which was often adapted to make it more child-friendly. So there was space to have those conversations with parents and guardians and decor and the like for that would make it more welcoming for children rather than being a harsh clinical environment.
And may we please have a shout out for the military, Mr. Grieve. Did, as in England, the military provide a great deal of help by way of logistical support, planning, the availability of making available of vaccinators, and setting up vaccination centres and transporting facilities in Scotland.
Yeah, likewise in Scotland, the military played a hugely important role, and the ability to flex and for the programme to pivot and expand, not least to respond to Omicron, but equally we turned what was the Scottish Exhibition and Conference Centre, which was our version of a Nightingale Hospital, into a mass vaccination centre. The military led that work and delivered it at breakneck pace. So the military were hugely supportive, and I'm immensely grateful for all they did.
And did they act as vaccinators as part of their functions in local vaccination sites?
They did. They did indeed.
In England, we've heard evidence that there were NHS-trained vaccinators used, obviously GPs, pharmacies and dentists, and also that there were there's a very large number of volunteers stepped forward in response to an invitation who were then trained to assist.
Yep.
There were also volunteers who volunteered themselves to act as stewards in community vaccination sites.
Yep.
You took a rather different approach in Scotland to the vaccination workforce and whether the degree to which you could utilise volunteers, didn't you?
So we used healthcare support workers, perhaps more than other parts of the UK, hence the protocol became incredibly important. So they were overseen by vaccinators. So, but we did use volunteers. We put numerous calls out and used, each health board had a bank of staff we could call on and we could train and deploy. But you're exactly right. We also sought support from third sector organisations who did a whole raft of activity, everything from meeting and greeting at the front door, helping to marshal car parks, to, as I've alluded to, physically transporting people who couldn't get to or from the vaccination centre as part of the programme.
So, to be clear about this, although you use volunteers who volunteered themselves to carry out vaccination, to be the vaccinators, they were trained up and formally, perhaps it's a matter of definition only, became healthcare support workers.
So there was a mix of both, but yes, we used volunteers and they were trained and qualified prior to deployment.
Turning now to the topic of how the Scottish Government addressed inequalities, may we take it, and certainly the evidence before the inquiry suggests this, that it was obvious there was going to be a problem with or an issue concerning the degree of take-up in certain marginalised and ethnic minority communities.
So we knew from other immunisation programmes that uptake wasn't universal for all groups.
Did you put into place certain bodies and structures to focus specifically on addressing barriers to access and trying to increase confidence and reduce inequality of outcome. So there was a vaccine equalities and inclusion team set up, and a national vaccine inclusion steering group, and directives given to the health boards, requiring them to formulate, to use the nomenclature, delivery plans for addressing these issues.
Yeah, if I may,
Please.
at the start, before we started the vaccine programme, we tabled a cabinet paper, and that cabinet paper set out the policy position for what would become the COVID programme, and as well as determining which ministers agreed to follow JCVI advice, that policy position sought to recognise that the programme would take a human rights-based approach, and therefore that guided our thinking on how the vaccine would be deployed, and all of the things you've alluded to about addressing inequalities was central to that.
Could we have, please, INQ 000240531? This is a document dated the 8th of March 2021. It sets out actions to the health boards for, to use the words of the document, inclusive vaccination planning and delivery. Just by way of example, we can see on this page, increase vaccine uptake in all community groups, area, communication, drivers of inclusivity, and then importantly, health board actions. Provide marketing material, consider alternative communications, consider particular use of social media and radio in a targeted way, local communication campaigns, sharing best practice. And then if we go down the page to page 2, please, down the document to page 2, we can see the various limbs of, to use again the nomenclature, delivery plans. So accessibility of transport and clinics, engagement, staff training, data and evidence.
Yep.
This is all self-evidently very laudable. It's quite high level, a direction to a health board to use clear and simple messaging to make sure vaccine centres are properly accessible. Did you leave it to a large extent to the health boards to decide for themselves how in reality these aims would be put into practice?
In short, no. So as well as the boards, each health board requiring to develop their plans, taking account of this, the team within government was reaching out to individual boards and supporting them. But we were also using some of the uptake data that we were getting, and if we were seeing evidence that uptake was lower than we were expecting, we would be directly engaging with that health board to understand what they were doing or what more they needed to do. And finally, I should also say the team within government that was leading on this work was also engaging with a whole range of groups and bodies that would be helping us understand was what we were doing working, and if not, what more could we do?
So let's just break that down a bit. So the COVID-19 Vaccines Policy Division, of which you were head, or some other division in the Scottish Government, would be on the phones, getting in touch with local providers, local groups, local community champions, trusted figures, charitable organisations, and making arrangements for proper engagement, proper communication to communities, as well as physically getting patients to sites. So it was being driven from the centre. You were involved in the minutiae of the practical arrangements and not just leaving it to the health boards to work it out for themselves.
Yeah, and on this and in many other things, as I alluded to, the mantra of the programme was nationally led and locally delivered.
And do you think that division of responsibility worked in outcome?
I think it did. Uptake for all groups wasn't as high as any of us would have liked. And in many ways, we're trying to build trust and credibility at a time, and that takes time. It does take time to build that trust and credibility with some of these communities that had a deep mistrust of the state or with the health system.
Do you assess, in hindsight, that enough was done both at the Scottish Government level and at health board level to ensure that barriers in the way of particular groups, marginalised groups, migrants, members of the Gypsy, Roma, and traveller community, that barriers were brought down or sidestepped, and that enough was done to encourage people to take up the offers of vaccination?
I suspect we could always do more. I think we did, I reflect we did quite a lot, but we could probably have done more. So I know in the engagement I talked about with the teams and some of these groups, there was really candid and honest discussions about how effective our interventions and support was, and as a result, we changed and pivoted our approach quite often, but we also engaged in different forums and that we hadn't traditionally engaged with, and as you alluded to, we used quite a lot of trusted community and respected voices, as well as using different centres, be it mosques or Black African churches or whatever it is. We sought to respond to the feedback we were getting from the communities themselves.
And finally, in relation to disabled people, you've already referred to the fact that initially, I think there wasn't a learning disability register in place in Scotland. Is that right?
That's correct.
Did you put one into place?
I don't believe there is one. I think the JCVI advised that we should use it, and Scotland didn't have one. I'm not sure if it still does, but we don't have such a thing.
So how did you resolve the problem, or whether you were properly identifying and making sure offers went to persons who were disabled?
So we took a liberal definition of learning disability and used that as the basis to call individuals forward.
Because learning disability was a particularly identified group in the cohorts of priority.
Exactly.
And did you issue guidance to health boards to assist them in identifying who you believed should fall within cohort 6?
There was guidance issued. It wasn't issued so much to health boards themselves, but it was through the system that called up people for vaccination or as part of the screening tool when people were either phoning to book an appointment or trying to book an appointment online.
Mr. Grieve, in your statement at page 34, we needn't go to it, you've kindly and thoughtfully set out a number of areas in which you believe that the Scottish Government innovated in a way that perhaps differed from the rest of the United Kingdom. And I just want to focus on 3 of the 7 or 8 which you mentioned, which appear to us to be quite different from the way things were done elsewhere in the United Kingdom. The recording of ethnicity in the data system at the point of vaccination was hugely significant, was it not? And you've already said that it had a great impact. You ran, secondly, a vaccine helpline. Was that of great assistance?
It was, because although we had a digital platform to allow people to book, not everybody had access to a digital platform. And equally, even those that did have access sometimes wanted to speak to somebody. So having somebody at the end of a phone to ask some questions was really helpful.
And lastly, you refer to the use of blue envelopes.
Yep.
What was that?
Yeah, so I can't take any credit for this, but it was a huge innovation. So at the very start of the programme, we had evidence that, particularly for older cohorts, getting an appointment was important. And when we were considering how that might land on literally through letterboxes, I seem to recall the Cabinet Secretary, Ms Freeman, who was, I think, the Social Security Minister beforehand, reminding us that not all white or brown envelopes that come through envelopes give you good news. So we moved to have a blue envelope. So as well as helping Royal Mail at the sorting office prioritise these letters, which they did, it also meant that when that blue envelope landed through the door, it was almost a version of push marketing. It was a prompt, a call to action to come forward. And I think, as I said in my statement, I seem to recall on social media there was loads of videos of people joyous at receiving their blue envelope. So that was a real innovation.
Some of the best ideas are very often the simplest. Brilliant idea.
My lady, that
That
concludes
completes your questions, Mr Keith.
my question.
Ms Mitchell will have some questions for you.
Mr Grieve, I'm instructed by Amar Anwar and Company on behalf of the Scottish COVID bereaved. Earlier today, you stated in your evidence, because supply was so constrained, the programme had a laser-like focus on ensuring we didn't waste vaccine wherever possible. So that drove us to a model which protected as much as possible all vaccine supplies that we received. It's the experience of members of the Scottish COVID bereaved that some health boards did try to use all the vaccines, but some threw them out at the end of the day, so that vaccines which could have been used were not. Were you aware that this was being done?
We did receive feedback from every vaccination centre. There was a daily stand-up at 8 o'clock every morning, and sometimes at the end of the day we were getting feedback from vaccination areas. There were some practical issues about when a vaccine expired. Once it had been defrosted, it was only allowed to be used for so long, and once it's diluted, it can only be kept for so long, and then it has to be discarded. We did assume, however, a vaccine wastage of about 5% at the start because of all the complexities with the vaccine. And I seem to recall in March 21, we were recording wastage at 1.8%, so far less than we were expecting to receive.
But did you know that some health boards were throwing them out at the end of the day? There's at least anecdotal evidence that some were throwing them out at the end of the day, some were phoning up, for example, relatives that hadn't had jabs and saying, please come in and we can give you the JAG there and then. So
I know some centres were having to discard them because of the expiry I've mentioned, but I also know some centres were opening the offer up to others. And whilst it was relatively small numbers, the challenge we had about deviating completely from the prioritisation list was it was sending out mixed messages to the public, who, as I alluded to before, many of whom we were asking to wait their turn and to ensure we vaccinated the most clinically vulnerable first.
So what you're saying was there was a balance between making sure that all the vaccines were used and making sure the wrong message wasn't being sent by some people hearing that other folk had got the vaccine first.
Exactly.
On that particular issue of mixed messages, my next question is this. It's the experience of the Scottish COVID bereaved that different health boards delivered the vaccination programmes in different ways. You've explained to us earlier in your evidence deployments, as you've described it. This has led, at least in the Scottish COVID bereaved group, some confusion between family and friends who lived in different health board catchment areas. What, if any, consideration was given to alerting and educating people to these differences in approach so that confusion wouldn't arise?
Yeah, so there was small and subtle differences between health boards, but generally speaking, all health boards used the same system for calling people up, for the ability to go online and book an appointment or phone the helpline and book an appointment. Where the vaccine was delivered would vary clearly from health board to health board, but it's probably important to note that the vaccine booking system allowed individuals to book an appointment out with the geographical health board, and that was particularly important as we came down the age cohorts, because somebody who, I don't know, lives in Fife but works in Edinburgh could get their vaccine in Edinburgh, for example, rather than have to travel back to Fife where they live.
I understand that there were differences and sometimes those differences were subtle, but my question was there any consideration given to alerting the public to those differences so that they were aware if their cousin in the Highlands and Islands said that they were getting their vaccine one way, that they would know that's okay, we're doing it differently in our health board?
Well, each health board had its own, and we supported them on their own local comms to their community, absolutely. But I suppose the point I'm making is the differences weren't that major. So health boards didn't, for example, we didn't have one health board vaccinating priority group 4, whilst another health board was vaccinating priority group 6. That didn't happen. All health boards moved in lockstep with the approach. So there was core fundamentals which were agreed across all health boards to avoid that very point you're making to me.
Moving on, it's further the experience of the Scottish COVID bereaved that vulnerable people within care home settings were being invited to attend mass vaccination centres. Firstly, I suppose, were you aware of that?
So do you mean residents or staff?
Residents.
I'm not aware of residents being invited from a care home to a vaccination centre. I can't recall of an example of being made aware of that.
Okay. I then will simply move to the next question, which was what, if any, consideration was given to ensuring that vulnerable people were not reliant on attending mass vaccination centres? You referred in your evidence earlier, for example, to the inclement Scottish weather at winter. Was consideration given to those sorts of things for vulnerable people attending centres?
Yes, there were, and equally, as well as part of the deployment going through the cohorts, there was often a period at the tail end of that cohort of mop-up, what we described as mop-up activity. So, if, for example, there was lower levels of uptake in the clinically vulnerable, for example, in an area, we would be exploring with the health board to see how much more we could do, and that might include, for example, more outreach activity.
More, sorry?
Outreach activity.
By that meaning asking people to come in from other areas or from other...
No, by that I mean vaccination teams going out to people rather than people coming into the vaccine centre.
My lady, I'm obliged. Those are our questions.
Thank you very much, Ms Mitchell. Like your colleagues, the other SROs, you obviously had an extraordinarily difficult task, Mr Grieve, and obviously performed it beautifully for the people of Scotland. So thank you very much for what you did during the pandemic, and thank you for your help with the inquiry.
Thank you very much, lady. Thank you.
Very well. I shall return at 20 to 12.
All rise.
Stevenson.
My lady, the next witness is Professor Dr. Gillian Richardson. Please can the witness be sworn?
I do solemnly,
sincerely and truly
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth, and nothing but the truth. Thank you.
We haven't kept you waiting.
No, not at all.
Please can you say your full name?
I'm Gillian Richardson.
Thank you for attending to assist the inquiry. Just some preliminary matters. You made a witness statement dated the 16th of August 2024, INQ 000501330. It runs to 66 pages and 105 exhibits. It contains your signature and a statement of truth. Can you confirm that you have read that statement recently and its contents are true?
I can.
Thank you. But before we get on to your professional background, I know you wish to say a few words about the efforts made by your team.
Thanks so much. Just like to thank my colleagues really in NHS Wales and Welsh Government, including all the Health Board, senior responsible owners, the Directors of Public Health, GPs and primary care contractors. Public Health Wales, especially the Vaccine Preventable Diseases Programme and the Vaccine Surveillance Team. Wales Blood and Transport Shared Services and the vaccine workforce who helped us to deliver the rollout of the vaccine, including third sector colleagues, volunteers and military colleagues.
Onto your professional background. You have a medical background. You initially worked as a GP, is that right, before progressing through the public health and research route to become a consultant in public health medicine in the early 2000s?
That's correct.
And you've held the positions of Director and NHS Executive Director of Public Health, in fact, two health boards in Wales, and in 2017 became Deputy Director in Policy, Research and International Health in Public Health Wales, is that right? Of most relevance to your evidence today, in late 2019 you joined Welsh Government on an informal basis, and was that to cover in the absence of a senior civil servant in the Office of the Chief Medical Officer?
That's correct, yes.
Effectively on loan from Public Health Wales?
Indeed, yeah.
Your work, of course, it intensified as the COVID pandemic hit, and you were at that time acting as a professional advisor to the CMO, formally seconded, and eventually stepping into the role of CMO COVID-19 response team lead on COVID-19 vaccines in Wales. Is that right?
It is.
In early June 2020, it was agreed that a COVID-19 vaccination programme board would be established in Wales, which you would chair. Please, can you explain what the purpose of that board was?
The purpose of the board was to plan for the development of a rollout of a vaccine. There were several candidate vaccines, so we had to prepare for any of those to be the one that would come first. We had to look at delivery models for planning the rollout to the sectors of the community that we had some prior notice but hadn't quite been decided yet. But we knew that it was going to be the elderly population, it was going to be particularly care home residents, health and social care workers, and that it was likely to be an age-based prioritisation rollout. So we were able to do tabletop exercises with all the health boards where we all had joint learning and basically did some tabletop planning.
You became the senior responsible owner for the COVID-19 vaccination programme, a position that you held until 2021. You point out that no formal appointment was made for that role. How was it that your appointment came about?
I think because I was the CMO lead for vaccines, and at that time it was quite a small team in Welsh Government. We had obviously a huge amount of efforts going on in the test, trace and protect functions, as well as emergency response. And I happened to have the most experience with vaccination in the team, having worked abroad on mass vaccination campaigns in Africa.
And in April 2021, your role shifted to Deputy Chief Medical Officer, and Claire Rowlands became the senior responsible owner.
That's right.
However, did you continue to maintain your existing relationships with the SROs in the other of the four nations, to attend meetings with them and to have a great deal of input into the programme?
Yes, indeed. And to be the public communication CMO sort of representative, yes.
You describe in your statement you formed a small core team in Welsh Government to coordinate vaccine planning and infrastructure in the way you've described. You also described staffing difficulties within the Office of the Chief Medical Officer for Wales. You were, as you've explained, stepping into a role that had previously not been occupied. And the pressures on public health services during the pandemic no doubt exacerbated those issues. Did the staff shortages that you refer to in detail in your statement prevent, in your view, the vaccination programme planning running properly or efficiently in Wales?
No, I wouldn't say it did, because we had excellent support from Public Health Wales Vaccine Preventable Diseases Unit, Dr. Richard Roberts then in charge, and his team. And also we had tremendous support from the delivery unit of the NHS, with Jeremy Griffiths stepping into the Chief Operating Officer role.
The Wales COVID-19 vaccination board, which you chaired, had a number of aims. I'm not going to reel through all of them, but were core aims to develop a delivery plan to manage and monitor vaccine uptake and equity of access, and to ensure that stakeholders and partners were informed on the progress of the development of the plan.
Yes.
Did you have a mission statement, and if so, what was that
We did.
mission?
Our mission statement was that we were to immunise as many as possible, as swiftly as possible, safely, with minimum vaccine waste.
And there were certain UK-led work streams, as they're referred to in your statement, such as vaccine safety and approval, prioritisation. That was being led primarily by MHRA and JCVI. And is it right that work wasn't duplicated by your team, that the emphasis of the vaccination board's work streams was delivery?
It was, although we did have a kind of sub-prioritisation. We had our own vaccine clinical and prioritisation group, so that if the JCVI guidance needed further interpretation to operationalise it, that group could be consulted. And we also sometimes made our own decisions on vaccine safety. So, for instance, we did not suspend the 15-minute waiting interval for clients with below 16 and with learning disabilities, or those in whom there may not be capacity to understand an anaphylactic reaction.
We'll come back to the clinical advisory group and some of their advice later on, but excuse me, in terms of the safety decisions, other than the decision that you have just explained, were there any other safety decisions that were taken differently, or did you otherwise follow?
No, sometimes I would write to the chair of JCBI seeking more urgent clarification on matters such as the age threshold for the safety of the AstraZeneca vaccine, because our programme was about 2 weeks ahead of the other nations at one stage, and it was at a crucial stage when AstraZeneca discussions were in train about the age range that was most appropriate for that vaccine.
And that was to seek clarification?
Absolutely, yeah.
The vaccination board had a number of subgroups, didn't it? We needn't go into all of their work, but they were subgroups for things like workforce, logistics, data and surveillance, primary care,
Yes.
care homes. In total, 7 subgroups dealing with those specialist areas. Was that structure of those specialist matters being delegated out to subgroups, was it effective?
Yes.
Was it overcomplicated, or did it work?
It worked really well because each subgroup had representation from key stakeholders and also from the deployment arm from health boards. We also had a stakeholder forum, which was basically initially part of the board. So right up from June 2020, we did have third sector and patient group representatives helping us in the planning and design of our programme.
The functions, finally, on the workings of the Wales COVID-19 Vaccination Board, the functions of the board were divided in June 2021, or perhaps a better word to use is transferred to the Wales COVID-19 Vaccine Delivery Programme Board.
Yes.
Can you explain, just in summary, why that change happened in June 2021?
Yes. I had been working with the Auditor General for Wales, and the Audit Commission had produced a report. And whilst it was complementary, there was obviously areas that we needed to look ahead to for the future. And in terms of mainstreaming a programme, there are phases when perhaps it is best to do that. So following the delivery of the primary courses in Wales, I requested a gateway review on the programme, and the gateway review recommended some actions which we took, and I became a clinical lead. My senior civil servant colleague Claire Rowlands became the SRO, and we had our chief pharmaceutical officer Andrew Evans and Jeremy Griffiths, the coup, acting as very much a gang of four at the centre of the coordination aspects.
Local health boards. The National Health Service in Wales collectively refers to the 7 local health boards, as well as trusts and special health authorities. In terms of the role of the health boards, what was the ethos of the approach in terms of the independence or responsibility that was delegated to them?
Yes. They'd been involved with us in the conception of the response, obviously. It was a distributed leadership model. It used the existing governance mechanisms which were there. So our Healthcare Inspectorate Wales has responsibilities to inspect our health boards and their services. They have responsibilities to report through to the Director General in Welsh Government, who is also the Chief Executive of NHS Wales. So we use the existing structures, but in a distributed leadership model where we set up the parameters for performance, for instance, or for the aspects they needed to consider, such as equity. and then we would monitor, and they would assist us to monitor their performance and also to share, reasons perhaps for exceptional performance in one area of Wales so that it could be a subject of learning for the others.
So using that example of equity, you set the parameters for what they ought to be achieving, but the health boards have discretion and flexibility to decide what programmes they will initiate to achieve that. Is that a fair example?
That's correct. Although we didn't leave them, sort of unsupported, we had a central vaccine equity committee, which arose from the stakeholder forum in due course, and we also had a vaccine equity action plan, which we asked them to report on at each of the monthly meetings.
Did that flexibility extend to the health boards in the way you've described? Did it cause any difficulties with a lack of parity across Wales, with different people having different experiences of rollout?
It sometimes led to misunderstandings, it's true, but the pace of the vaccination programme was so intense that usually any disparities were extremely short term, because all of the health boards achieved our priority groups 1 to 4, were all vaccinated, and the offer had been extended by mid-February, so in line with our first vaccination strategy.
We've touched on the advice of the JCVI. In your view, was there significant or sufficient, rather, Welsh participation or engagement with the JCVI in its decision making?
We had an excellent observer, Anne McGowan from Public Health Wales, who went to every JCVI meeting and had done for the years previously to the pandemic. We also had a Welsh Government observer that we were able to put in place. What we didn't have, which I think was important, was that we didn't have a voting member. So we had observer status. So in that respect, as a devolved nation, we did I had to perhaps sometimes highlight things to the chair that I considered were issues that needed that we needed to have addressed.
And would you consider that would be an area that might be improved upon?
Yes, I do believe that each of the devolved nations needs a voting member, and I do believe that in the scientific subgroups that look at the research evidence in particular, and particularly also perhaps for the MHRA, if I may say so, that it would provide strength and also help understanding back at base if the devolved nations had representatives.
Wales had its own vaccine clinical and prioritisation group, as well as its own moral and ethical advisory group. Did both of those groups offer advice on the advice that had come from the JCVI, how to interpret it and how it might operate in Wales?
Yes, indeed. And our Senior Medical Officer, Dr. Heather Payne, sat on both and chaired both.
I want to move on then to the issue of the allocation of vaccines to Wales, and the inquiry has heard that the Barnett formula was the basis for allocation. In simple terms, the total number of vaccines provided to Wales was a share of UK vaccinations according to population size. You expressed some concerns about the use of that formula in your statement. Could you explain what those are, please?
Yes. In brief, the Barnett formula is based on a whole population estimate and what proportion of that each country should be allocated. But if you have a vaccination programme that is targeting specific age bands in the population, the age bands are different between the two countries. So, for instance, if we were required to immunise groups 1 to 4, then our share of, say, the over 60s in Wales by 10-year age bands was 26% of our population, whereas for the combined England and Wales population, it was 22.7. So, in fact, we recognised that there was a gap. Also, our all-cause disability-adjusted life years calculation in Wales was 7.5% higher than that of the England and Wales average in 2019. So we felt that we were we were nervous that we would not have enough allocation should there be 100% uptake. And in fact, for our care home residents and over 80s, we came fairly close with 98% on the first dose. But in the event, BEIS were always very generous in giving us the option where there were vaccine batches that were approaching the end of their shelf life. We were often offered these and accepted them gladly.
Do you have any suggestions about what you say might be a better way of approaching allocation in a future pandemic?
I think we need to make much better use of our statisticians, if I'm honest, to look at the population structure that will be targeted and the order they'll be targeted. So that, for instance, if there's a need to immunise children, as opposed to the adult population, that those areas of the country with very young populations, so London, Birmingham, other areas, would obviously have more share. But on this particular occasion, we were looking at the elderly and the clinically at risk.
In terms of other types of engagement between the four nations, there were regular, I think from December 2020, weekly meetings between the SROs. There was also a WhatsApp group for more day-to-day quick communication.
Yes.
Was that that package together of the meetings and the WhatsApp contact, a useful relationship and one which might be a good idea to repeat in the event of a future pandemic?
Yes, definitely. The meetings afforded us the opportunity to involve our teams and to ask officials for more guidance. But the WhatsApp day-to-day conversations were an invaluable peer support mechanism as well, and a chance to be honest and transparent and candid with each other.
An issue arose between the nations as to a UK-wide vaccine delivery plan. In your statement, you explain that a draft version was shared by UK government and SROs in each nation on the 8th of January with a request for review and contribution from Wales, Scotland and Northern Ireland. Was it possible for Wales to agree a joint UK plan at that time?
It could have been had there been earlier notice, but we were informed about it very late on, the Monday before it was due to be published. And we only actually received the draft version in full on the Friday evening, by which time, obviously, that meant a very, very short space of time to consider it and no time for consultation. It also meant that, because in Wales we have a duty under the Welsh Language Act to produce every public document bilingually. So to have put our own stuff in and also translated all that that had not actually yet been completely finalised from the UK government would have been incredibly difficult.
In your view, would there have been, because Wales of course went on to publish its own strategy, would there have been benefit in a four nations plan, or given the different deployment approaches, was it sensible to have separate plans?
I think there would have been strength from a public confidence aspect to have had an overarching four nations introduction and then a section for each country. But as it was presented to us at that time, and I appreciate that the matter was pressing to get milestones for delivery out. However, it came across as an incredibly Anglo-centric document that I don't believe any of the four nations signed up to eventually.
So presumably, if this scenario arose in the future, it's earlier collaboration and notice, which would be helpful.
Yes.
Moving on then to that Wales vaccination strategy, which was first published on the 11th of January 2021. I know that there were revisions to it, but this initial foundational document. Perhaps if we could take a look, INQ 000410079. this is the strategy itself. And if we scroll down, please, to page 4. Section 2, an overview of where we are now. It sets out the key areas. If we could just come back out, please. It sets out the key areas that the strategy is focused on, to work closely with the UK government on supply, to make sure that there is proper vaccination infrastructure, and keeping up to date and informed. It sets out the scale of the challenge, the biggest vaccination programme in history. The strategy at paragraph 2 states that it's important to be clear about the supply challenges, the logistics around first vaccine in particular, and that health boards are operating a just-in-time vaccine delivery mechanism as supply arrives. Can you explain what was meant by that, please?
Yes, so we were very concerned, obviously, about the Pfizer vaccine's storage requirements, and we had, in fact, entered into an agreement with Bayes and Pfizer to have direct deliveries to Wales, and we were really, finding out about that vaccine in the first instance, but because the supply chain was very variable at that time, and if supposing we had a batch that didn't receive approval by the MHRA, that could be half of our supply for that week. We operated a system with all the health boards where they could order their vaccines, and we would deploy them so that they had a continuous supply of everything we had, basically, coming into Wales, and that way it enabled them to deploy swiftly as well, whatever we were given.
You mentioned the Memorandum of Understanding. Perhaps we could deal with that now.
Yeah.
That was a memorandum of understanding between the Welsh Government and Bayes in respect of delivery of the Pfizer vaccine. Could you explain in summary what that understanding was, what it allowed Wales to do differently?
It meant that our supplies did not have to go through Public Health England, and it meant that they could come straight to Wales and be deployed immediately. There were very strict regulations on the amount of times that a vaccine could be moved, where it was to be stored, once it was constituted, how long it could be used for, 6 hours, for instance. So cutting out the middleman, if you like, helped Wales to speed up our vaccination delivery.
And was that particularly needed in Wales because of some of the rural areas being harder to reach, and meaning that an extra transfer would
Absolutely, we just
make
didn't have
it
the
unviable?
luxury of that extra transfer.
So returning to that document, please, at page 8, to briefly look at the model that was adopted. We see, just scanning here, that there is a plan for mixed delivery through mass vaccination centres, primary care, surgeries and mobile units, and aim to have one vaccination centre in each county of Wales, and recognising that local convenience is served by reaching communities through primary care, and that's also safer for older and vulnerable groups. At this point, 100 GP practices had been engaged, and there were plans to get up to 250 before the end of January. And you also mentioned the importance of community pharmacies. And if we could look at page 9, please. This is the mention at the top of the page of mobile units. Were they already being used in order to reach
Yes.
care homes
Indeed.
and other vulnerable groups?
Yes, and shortly after this strategy was published, by the 26th of January, we had over 387 GPs came on board, 33 hospitals, 38 mobile teams and 52 mass vaccination centres, and that represented 9% of the population being covered with their first dose. And we also had a particular target to immunise all 16,000 of our frontline Welsh ambulance staff as part of the essential infrastructure resilience for the NHS.
We see there as well reference to how appointments are made. In Wales, was it the Welsh immunisation system?
Yes.
For scheduling appointments and also recording and reporting on vaccination activity? Was it all in one system?
It was an integrated system developed at haste by the National Wales Information Service, now renamed, but a lady, Jill Davison, and her team worked non-stop, really basically through a whole weekend and a week, to convert our child health immunisation system, which was an integrated call, recall, etc., and data capture system, and adapt that for the whole of the adult population in Wales.
So this was operational at the time of publication of this document, which was the 11th of January?
Yes.
How effective was that system in particular in allowing you to monitor uptake and any gaps in uptake in particular groups?
It was extremely helpful, and it enabled us to look at each health board's performance in terms of their areas, their GP clusters, for example, local networks of GPs, their gender, their age ranges, their categories, what cohort somebody was in that had been immunised. And then later, as we were able to develop better systems to look at ethnicity and other protected characteristics, it enabled us to have an enhanced vaccination report, enhanced from the daily, so that we were able to look at areas that may be doing very well or not doing well with particular groups.
Thank you. We can take that document down. The strategy, we needn't go to the page, but it also states that at that point, there was only 1% of wastage in the first few weeks of the national vaccination programme. And you go into some detail in your statement about the fact that it's your view that Wales maintained extremely low levels of vaccine waste.
Yes.
How was this achieved in Wales, please?
We had a pharmaceutical team with very extensive training in the use of the vaccine and in supporting health boards. So every hospital pharmacy team was involved, every health board had pharmaceutical leads. So our team in Welsh Government would work with them to make sure that the vaccine was constituted correctly. Many of our mass vaccination centres all in fact, I think had pharmacists on site, so to ensure good preparation. We also had systems so that at the end of the day, we had end-of-day doses and we had reserve lists. We had also means of not unbottling and reconstituting vaccines that were not going to be needed. So about an hour from the closing centre times, the management of the centre would look at the queues, would make sure that the number of vaccination stations, because there could be, say, 30 in a large centre, that they were slimmed down to maybe 5, and below. So just for the last half hour, we were actually only opening exactly what we needed. We may have maybe 3 end-of-day doses. But at the beginning, obviously, with large numbers coming through, we realised that this was a distinct risk.
Moving on now to the issue of equity of uptake of vulnerable groups. Wales had a dedicated surveillance programme designed by Public Health Wales to track inequalities, is that right?
Yes.
If we could have up on screen, please, INQ 000182538. This is the vaccination equity strategy for Wales.
Yes, this was written by a registrar on placement with us, who I was supervising, and who did a fantastic job. Actually, she was from a background of inclusion health.
And published in March 2021.
Yes.
Could we go to page 6, please? This summarises the position emerging from some of that research conducted, I think, by Public Health Wales, certainly teams within government. If we look at the third or fourth paragraph down, in Wales, there is emerging evidence that attitudes to vaccination are impacting on uptake of vaccination in some groups. What was identified was an inequity gap in uptake between people who live in the most deprived communities in Wales compared to those who live in the least deprived communities. And the vaccination uptake gap is even starker when comparing uptake in minority ethnic groups compared to people of white ethnicity. In over 80 is a difference of 14.1% we see there compared as compared between those from Black, Asian, mixed and other ethnic groups. Thank you. We can take that section down. It perhaps goes without saying that from a public health perspective, these disparities were not a surprise to you or to the other teams involved in this work. Do you agree that they were foreseeable before rollout began?
Yes, they were foreseeable because we had seen them with our influenza programme for adults as well. The only programme that seemed to achieve true equity in Wales prior to this, we knew that school nurse-based delivery of the school-leaving booster for children was much more equitably distributed because that was a universal service.
What is your view of the underlying causes for this situation in Wales?
I think it's not unique to Wales, but trust in the government is extremely important. Trust in the clinicians and the medical professions. Transparency over safety and of any concerns are really important. I think that there are traditional vaccine indecision over is this vaccine safe for me? Is this vaccine forbidden for me because of my religious or cultural view? And is this vaccine accessible to me? Basically there's a whole gamut of factors which will apply differently to different individuals. But certainly building up trust outside of a national crisis is something that's a precursor to good healthcare and good sort of receiving of healthcare, allowing yourself to be vaccinated during a pandemic. It's very difficult to fix in a crisis what is damaged in peacetime. Because you do not have the luxury of time to build up relationships. So we tended to use our trusted community leaders and networks, our existing frameworks such as our disability forums, our Black and ethnic minority engagement groups in Welsh Government, and we had very good relationships on our stakeholder forum. Which was, sort of originally part of the board and then split off to have its own discussions. And out of that grew the Vaccine Equity Committee.
Yes, so that committee was set up and held its first meeting on the 22nd of March 2021.
Yes, but all of the stakeholders would have been involved since June 2020.
2020. Looking then at the plan and the actions taken during the pandemic, I appreciate you're saying that it's better for these relationships to have been established beforehand. But in terms of what was done, both following on from the report we've just seen and after the Vaccine Equity Committee was set up, did the work focus on particular groups, so those with physical, sensory and learning disabilities? Yes. Mental health patients and people who may have substance misuse issues or be experiencing homelessness, people with uncertain immigration status, members of ethnic minority groups and also residents in areas of economic deprivation. Were those groups the focus of the will?
Yes, and that's all outlined in the Vaccine Equity Committee Action Plan, and they had 4 groupings really with clusters of third sector and community representatives working with the health boards on the best way to actually reach their communities.
The detail of that action plan, I won't attempt to list now, of course, it wouldn't be proportionate, but examples, ensuring information was available in different languages, providing translation services, ensuring information was in accessible or easy read format for people with disabilities, community transport options, pop-up centres, use of trusted voices in communities to spread information. To add to that list, just a couple of matters I want to ask you in more detail about. Within the list is reassurance for people that their information would not be shared with immigration authorities if that might be a barrier to them seeking vaccination.
Yes.
Can you explain, was the situation the same in Wales as in England for people with uncertain immigration status when it came to the charging provisions that might apply to healthcare?
No. I think it's fair to say that Wales never subscribed to the hostile environment policy in that sense of ensuring that our data, our clinical data on patients was never shared with the Home Office. We never entered into a data sharing agreement. In fact, we opposed it in Wales, I believe. In terms of the vaccine programme, we liaised with Doctors of the World and their work, and we attended the meetings that were happening on a national basis. Wales had declared that it would has an ambition to be a nation of sanctuary. So there was a Welcome to Wales website with signposting, but also there was a series of meetings, about 6 meetings in fact, with the Home Office, with the Home Office accommodation suppliers, with third sector groups representing migrant health, and all health boards and Public Health Wales, Welsh Government. So there were troubleshooting of ways and means to encourage people to come and be vaccinated. There was still a lack of vaccine confidence, especially amongst those that perhaps had not come directly to Wales. But I do believe that the various agencies together made a really helpful impact for that group.
To be clear, that the vaccination programme and treatment for COVID-19 was, of course, exempt in England from those charging provisions, but the difficulty was that there are concerns that that message didn't get through to people, or that they may have lacked confidence in information, that in their information wasn't going to be shared, as the government had assured them it wouldn't be. So are you confident that in Wales enough was done to let people who had uncertain immigration status and might be worried about that know that it wouldn't apply?
There's always more that can be done, but particularly, the fact that things like people with maternities are very nervous if they've been in England first, that they will be charged. And so all kinds of layers of misunderstanding that the 4 NHS systems are not actually identical can arise. So we tried our hardest to address those issues.
I'm sorry. I couldn't quite hear, and I don't think stenographer did either. People with
maternities, for instance, people who people are very concerned if you're an asylum seeker that you might be charged for your hospital treatment for if you have a maternity.
So, I'm so sorry. I'm just not following. If you have maternity,
if you have a baby in a hospital, will you be charged? Basically.
I see. So if you're, I follow. Thank you.
Just one other point of difference I want to ask you about when it comes to care. In Wales, was there a requirement to be registered with a GP or to have an NHS number in order to obtain a vaccine? A particular challenge in Wales was rural communities. What steps were in place to ensure that they had proper access to vaccines?
All of our health boards have been working with their rural communities for many years. Our NHS is fortunate in that we haven't had a reorganisation since 2009. So, in fact, our health boards know their communities very well. They've worked very closely with their general practitioners and other primary care contractors and with community health services. So, for instance, when the Pfizer vaccine arrived and came in trays of, just under 1,000 doses, then we were delighted that some of our GP clusters volunteered to, do a vaccination weekend together. So, for instance, we had the Llŷn Peninsula in North Wales GPs, we had the Denbighshire GPs, we had the Bridgend GPs, all, giving very innovative cluster delivery, which was new. That was completely new. So our health boards worked very closely to make the most of the resources in their area.
And finally, there were some people for whom the prospect of attending a mass vaccination centre might be worrying because they have clinical vulnerabilities.
Yes.
Which make the fear of infection particularly acute for them, and may make, in fact, using public transport or getting to vaccination centres difficult. What was done in Wales to accommodate those who might be clinically vulnerable so that they could access vaccines?
We worked with members of those communities to ask what would be helpful. In response, sometimes the vaccination was delivered in an outreach format. So, for instance, with substance misusers, we worked with agencies to deliver vaccine closer to the ground for those with chaotic lifestyles that would not be able to keep appointments. We also worked very closely with our learning disability third sector organisations and representatives so that we had learning disability nurses in our clinics if we had, for instance, individuals with autism that needed particular treatments areas and quiet spaces. And some of our nurses, would go to the car and talk to the person and help make them feel at ease first. So we also had drive-through vaccination, actually, which if people preferred that, they could access. And of course, our GPs knew their patients very well and were able to accommodate those that were worried about going to a public place.
Moving on then to some issues which concern Wales being flexible in its deployment plan when it came to the way that JCVI advice was implemented.
Yes.
You explained in your statement that Wales at one point permitted commencing invitations to the next JCVI priority cohort group when at least 50% of the cohort group above had been invited. Can you explain how that worked and
Yes.
whether that is a correct summation of what was happening?
Not quite, because 50% of the cohort had to have been immunised, actually, and the rest of the cohort had to have been offered appointments. And at that stage, they could, to avoid the lag that sometimes happened in between cohorts, they could get ahead on the next cohort and start inviting them.
You talked before about Wales being a little ahead. Is that part of what sped things up in the early stages?
Yes, indeed. But also the fact that we were really promoting the immediate use of our stock and, querying whether there should be any stock actually in freezers or fridges because really it should be in arms as soon as it arrives.
Was there a danger in doing that there would be fewer available appointments for those in the higher priority cohorts who should have been getting
No,
them
not
first?
at all, because the requirement was that they had to have been offered their appointment.
Another area of flexibility, perhaps, is the guidance on unpaid carers.
Yes.
And so the clinical advice group that we've referred to a number of times offered advice on the definition of unpaid carers and interpreting JCVI's definition. Wales amended their approach slightly. How did they do
Yes.
that? How did you do that?
Having consulted with our ethics and advisory group and our vaccine clinical and prioritisation group, there were some concerns that the definition of unpaid carers needed to be slightly more flexible. In particular, if there is an unpaid family carer for a vulnerable family member, there's often two people at least who will be looking after them in a very close way, because no one person can do it 24 hours. So basically, our unpaid carers were invited to come and to self-identify. We obviously knew of some that were in receipt of DWP or local authority registered. They may have been known to their GPs, but many others were not and were hidden unpaid carers. So we asked all our health boards to promote a central portal on Welsh Government where people could self-identify, and the health boards would then get in touch with them and send them appointments. And the Welsh Government published guidance on the 24th of February about this to publicise it. So that each health board had this local implementation inclusive approach, working closely with their local authorities, because obviously we have that benefit of the very long relationships in our structures with local authorities.
And did you find that led to a flooding in any way of the system, of more people than perhaps were suspected to be unpaid carers self-identifying?
No, I think it was about right.
There was also a flexible approach adopted on the JCVI guidance around learning disability and the distinction between people with a severe and profound or mild or moderate learning disability. Did the Welsh Moral and Ethical Advisory Group advise on that issue, and what was the outcome?
They did, but we also had learning disability charity members on our stakeholder forum and on our vaccine equity committee. So there are a variety of sources of advice on that, including from members with learning disabilities themselves. And we obviously were needing to implement the advice of the JCVI and keen to implement it. Individuals with Down syndrome were going to be vaccinated in cohort 4, but others would be immunised in cohort 6. But the classification of disability is not framed as the guidance came out from JCVI in terms of the public or in terms of the learning disability registers, for instance, that our GPs maintained to exercise their annual checks on those with learning disabilities. We've had that for some years, including also those with serious mental illness. So we decided that, again, we would have a permissive approach. Our minister was at pains that no one was to be left behind, and it was very difficult to strictly define who was severe or profoundly learning disabled.
So it captured then everybody with a learning disability?
It captured anybody that we could identify as having a learning disability. And we knew that even for those with mild to moderate, there were much poorer health outcomes, for instance, just generally in terms of their health care.
A different topic entirely, please, vaccination as a condition of deployment, which of course was not implemented in Wales.
No.
That was a ministerial decision, but it's one that you had some input to because you contributed to a cabinet briefing paper in 2021 about the advantages and disadvantages of the approach. Can you explain, please, why Wales did not go down that route?
Yes, it's interesting. Earlier on in the week, Heidi Larson talked about the fact that making smallpox vaccination mandatory actually led to the first anti-vax movement because people resented coercion And so it's sort of, that's the context which perhaps I'll frame this. But we had very high uptake rates, actually. By the 24th of June, we had 92.5% of our care home workers had had their first dose, and 86.5% had had their second dose. The Social Care Working Group of SAGE advises 80% coverage for care homes, and our lowest health board coverage was actually 89%. So with our highest being at 98% dose 1, 94% dose 2. So we could see that there was a challenge for some areas, particularly in London, and we did feel that it was very difficult for colleagues in England. But for ourselves in Wales, we did not feel that we needed it. We felt that the emphasis should be more on giving information, helping to assure any that had concerns, and also on enabling and requesting that the workers in care homes, who are often quite lowly paid, were able to have a vaccination in work time, not in their own time, when they may have childcare responsibilities, when they may have other issues that would impact on them. So we felt that it would need to be continuously monitored, because the workforce is a very rapidly changing workforce. There's a high turnover. But our Chief of Social Services, our Chief Medical Officer, regularly wrote to the care sector to encourage them to continue with this extremely high level of take-up, and to congratulate them really on that.
Well, why do you think that Wales was able to achieve that high level take-up amongst care home workers in particular?
Our very first initial strategy had set out that we would we aimed to immunise our care home workers at the same rate as our care home residents, because it was an environment in which we needed to protect everybody, in particular to make sure that carers didn't come in to work and infect the residents.
Moving on, VDPS,
Yes.
please, which was, of course, a matter reserved to the UK government. But are you able to give your views on how that scheme operated in Wales?
Yes. Obviously, it's not a devolved matter, and the Welsh Government, this is not their opinion, but my own personal opinion is that any scheme that looks at compensation needs to be a sliding scale and not a threshold. It needs to be very responsive, and it needs to take into account damage that has occurred for which somebody has worked very hard to rehabilitate from. So, for instance, if somebody is in a coma for 6 months and then recovers and has 49% disability, there's no compensation for the time that they completely were unable to work, support their family, be involved with, loved ones, etc. So it's very important that if we're calling people to accept a vaccine which we believe to be safe but may have a minuscule, 4 in a million chance of having a very serious side effect, that we support those that had the very serious side effect. And I think we saw the effect on the impact video, that not having a scheme that seems empathic, that seems understanding and accessible, and that gives reasonably, responsive timeliness in its decisions is extremely important.
Perhaps ought to clarify that it's not a compensation scheme, which I think is the language that you used, but you have explained your own personal views on the effectiveness of the vaccine damage payment scheme. The MHRA yellow card scheme, of course, operated in Wales.
It did.
What was your view on the effectiveness and the awareness of that scheme. And by effectiveness, I'm not asking you to comment on safety matters, but in terms of the deployment perspective, whether people who were receiving vaccines were sufficiently aware of it.
It's a scheme that works in peacetime. I think in a crisis we needed more enhanced active surveillance, in actual fact. The problem is that although the MHRA may have been seeing reports, if the reports indeed were sent, because many members of the public are not aware of the yellow card scheme, and junior doctors in training, are told about it but may not be experienced in its use. So I think seeing other reports on an active map of reports of strange, rare events would help clinicians to put the pieces together themselves. I think that the MHRA did a fantastic job in keeping the public informed. But this particular scheme is probably one that needs refreshing or re-promoting. I think that the introduction of an app that you can report on is a really good step, and that's been taken. I think earlier alerts on possible signals to clinicians is needed, and an enhanced surveillance. And an example of that might be the enhanced surveillance that took place when we initially had our COVID cases. So we have a high consequence infectious diseases policy. Everybody knows what to do if they get one of these HCID cases. And the UK HSA gives monthly summaries of global HCID events. So there is a global surveillance mechanism for it as well. I think the other thing about high consequence infectious diseases is that there is referral to specialist centres, so that expertise can be gained by a very few specialist centres. And in the case of those who had vaccine damage, I think this might have helped with learning. We talk about the first 100 cases, of a HCID being where you learn. And obviously, with the rate that these were happening, that would have to be global. But to have some, pooling of expertise in the rapid identification and treatment of anything that could be, for instance, cerebral venous sinus thrombosis with thrombocytopenia, would have helped clinicians to learn more about management.
And just finally, what information, please, in summary, was available to people who were receiving their vaccine in terms of safety? And was there a protocol in place in Wales to set out what they needed to be told so that clinicians
Yes, there was.
understood?
There were detailed protocols of, standard operating procedures for our vaccine delivery, and every patient received a patient information leaflet. There were also other sources where they could go to for advice on safety, and every member of staff was trained to have those conversations. In fact, people were encouraged to discuss with their healthcare professionals any concerns before they accepted the vaccine. Then we kept on with the 15-minute wait, much longer than everybody else, until the temporary authorisation to suspend it went, and it was permanently suspended. And at that time, having observed that it had been safe for the rest of the UK, we did abandon our 15-minute wait as well.
Thank you. Those are my questions.
Thank you very much, Mr Stevenson. Mr Dale, I don't know how much Mr Stevenson's left you of the questions I've agreed to, but... Can you see, Mr Dale?
I can.
Right, I'll try to do this without the... Right. Given the pre-existing research and evidence of lower uptake of vaccination programs generally amongst ethnic minority groups, as you've spoken about, do you accept that the disparities in uptake of the COVID-19 vaccine were foreseeable? and ought to have been anticipated with active mitigation incorporated into the planning and decision-making around the vaccine rollout.
I agree.
Okay. And thanks for that confirmation. And in your paragraph 237 of your statement, in discussing mistrust about the vaccines, you said, and I quote, the fears of members of some ethnic minority groups, such as some Asian and Black African individuals, was, in my opinion, a result of mistrust and authorities based on past and present experiences, including the history of European colonialism and slavery, end of quote. And just put that in the background for now, considering that the core message for vaccine uptake was that the benefits of taking it far outweighed the risks. So holding those two things in mind, my question is, how does the historical mistrust between Black, Asian, and minority ethnic communities and authorities, such as you've described it, affect the ability of that core public messaging on vaccines to resonate within these communities?
Thank you. I think it's very important for that message to be transmitted by the right messenger. So it's very important to involve trusted voices. So for particular faith-based communities or for particular cultural or ethnic minority communities, Gypsy, Roma, traveller communities, for example, as well, it's essential that the messenger is trusted. And so the use of healthcare professionals from those backgrounds, the use of trusted community leaders, the extremely helpful advice from the central, for instance, the Muslim Council of Great Britain on the fact that the vaccine was permitted, it was halal, was extremely helpful, and similarly for advice from Jewish bodies as well. So we do need to work much harder in peacetime to make sure that we have a distributed communications mechanism using the voices that people in the communities we know and anticipate are going to have lower uptake are based.
Very well. Thank you.
Thank you, Mr. Dale. Thank you very much, Professor Richardson. As you said at the beginning of our evidence, it was a team effort to deliver the vaccines around the country, and obviously very grateful to all of them and to you for the part that you played in delivering the vaccines. Thank you very much for the help then and for your help to the inquiry.
Thank you.
I shall turn at 1:45.
All rise.